Okay, just a minute. So management of infection wound and SSI. Just a second. All right. So the outline is what is wound infection, and we're going to talk a bit about surgical site infection, basically the prevention and treatment. So wounds, as you probably know, there are acute wounds and chronic wounds. There are other ways of classifying wounds, but these are the common ones. Acute wounds, for example, laceration, burns, surgical, you name it. And then the common chronic wounds are pressure sores, venous ulcers, and diabetic ulcers. Okay, we've been through wound healing process before, so I don't need to repeat that. So what is wound infection? It's important to understand that health or the absence of infection is not actually the absence of bacteria, because bacteria is everywhere, and is that elegant balance among humans and the resident flora and the flora of the environment, which basically constitutes health. Okay. So once that balance is disrupted, for example, by wound, then you get problems, because the skin microbes or commensals will invade and basically elicit infection. Okay, so there are a spectrum of bacteria in a wound. I think you probably come across this before. You get contamination, which is non-replicating organism or bacteria. You have colonization. There's no replication but no tissue damage. There is replication but no tissue damage. You have critical colonization, which is a transitional state, and this may delay wound healing. And then you have the obvious wound infection with basically tissue destruction by the replicating bacteria. Okay, so how do you diagnose wound infection? You can go by clinical. It's you know, the common signs: the warmth, erythema, edema, and pain sometimes. Or historically, it is defined as through microscope 1 to the power 5 of colony forming unit program of tissue or per mil of fluid. Okay. Now, because the virulence of among bacteria differ, that figure is not always true. Okay, because very virulent organism, you don't need that amount of bacteria to basically say that the wound is infected. There are also some synergism among bacteria. That means to say that presence of 4 more different species can work together and basically cause delay in wound healing, but not necessarily elicit the signs of wound infection. So sometimes we take a culture from wound, you get this multi-organism, but you know the wound doesn't look infected, and you get multi-organism, but the wound's still not healing because of this synergism among the bacteria. So SSI, basically it's an infection that occurs in a wound created by an invasive surgical procedure. Okay, so it needs evidence of symptoms and signs of infection and microbiological evidence. Okay, and most noticed within the 30 days, usually happens between 5th to 10th day post-op. But if you have an implant or a synthetic material used in deeper tissues, then that period may be longer. Okay, and it can be very trivial, and it can also be life-threatening, and can cause different outcomes: poor scars, contractures, and cause psychological problems as well. Now, the Center for Disease Control of the of USA define SSI. A definition of SSI gives 3 levels. You have the superficial, incisional, which basically at the level of skin and subcutaneous tissue. You have deep incisional SSI involving the fascia and muscle, or you have the organ or space infection, which involves other part of anatomy, example, joint or peritoneum. Okay. Now, the pathogenesis of SSI occurs basically due to contamination of the wound. So you have, it can be either endogenous from the skin or the organ itself, or exogenous from the instruments or from the environment. Okay, and it's versus the host immune response. Risk factors of SSI, basically this is a risk factor for wound healing, really. Age, increasing age, underlying illness, ASA more than 3, diabetes, malnutrition, steroid, low albumin, radiotherapy, obesity because of poor vascularized tissue, low immune response, because of more difficult surgery, so you're at risk of developing SSI. Smoking, duration and quantity, wound classification, level of wound contamination, and then site and complexity of procedure. The longer the duration, the higher the risk of SSI. There is what is called NNIS, or National Nosocomial Infection Surveillance System Risk Index. Basically, you can score the risk factors of developing SSI. Okay, I'm not going to go through this. You can read it on at your own leisure. Now, let's go through a bit about what you can do to reduce the risk of SSI. Okay, just to recap the level of evidence: level 1, level 2, basically it's RCTs, level 3, level 4, and level 5. So based on the strength of the studies. Okay. Prevention treatment. So you can divide it into 3 phases. The steps you can take preoperatively, intraoperatively, and postoperatively. Pre-op showering, does it help? Level 1's evidence to say that chlorhexidine is better than not having shower at all. However, there's no difference if you use chlorhexidine or just normal soap. So basically, if you're having major surgery, especially, for example, abdominal surgery, ask the patient to shower at least with soap or detergent. You don't have to necessarily use chlorhexidine, because level 1 evidence shows that there's actually no difference. Hair removal, for example, if there's the area that you're going to operate on have lots of hairs, there's actually no difference between hair removal versus no removal. So this is, I find, for example, for operation at the scalp, I tend not to remove hairs, but some surgeons, probably because of the ease of the operation, they prefer to shave it off. But there's actually no difference between the risk of SSI between removing or not removing hairs. But if you're going to remove hairs, you should use clippers or depilatory cream rather than razors, because razors tend to cause traumas to the skin, which can cause superficial skin infection. About the timing when to remove the hair, if you need to, there's actually not enough evidence to determine whether timing is important or not. But the practice is usually you do it in theater rather than the night before or you know, a few hours before the surgery, because basically if you don't want any trauma to the skin and cause infection prior to the surgery. Another one for pre-operative phase is OT staff attire. There's no studies on scrubs, caps, and shoes, but obviously it's for your own protection as well. So face mask, actually there's no evidence. This is a level 1 evidence to say that face masks influence SSI in clean or dirty surgery. So actually it doesn't affect your the wound, but for your own protection, I suppose it's advisable to wear a mask. Okay, so if anyone asks you why not wearing mask, you can say that actually no evidence to say that this leads to high risk of infection. Okay, this is level 1 evidence. Nasal decontamination for patient, is it necessary? Nope, it doesn't affect or reduce the rate of SSI. For example, using mupirocin or chlorhexidine. I suppose this is more relevant to ENT. Bowel prep. No difference in SSI between bowel prep and no prep. Pre-operative phase, antibiotic prophylaxis. In clean to dirty surgery, it does result in fewer SSIs. But in other surgeries, for example, hernia repair and lap chole, is basically not effective. Okay. And lowest SSI rate is when you administer it between 0 to 2 hours pre-op. In clean and clean connected surgery is level 2. Hand decontamination. No difference between using alcohol hand rub on povidone or chlorhexidine. This is particularly applicable when you're doing LA cases. You know, in between cases, the first case, you normally scrub it properly using the povidone and chlorhexidine, but the next or subsequent cases, you actually don't have to scrub. You can actually just use alcohol hand rub. Especially if you have sensitive skin, you don't actually have to use or to scrub your hands every time. So this is level 1 evidence. Incised drapes, I think we do have this at SASMAC, I think. If you used the incised drape, this drape that you put on over the skin, the non-iodophore one, this is just a plain one, actually increase the SSI risk compared to not using one. Okay. However, there's no difference when you use the iodine impregnated one. Okay, so if you're going to use one, use the iodine or iodophore impregnated one. Disposable or reusable drapes and gowns. No difference in SSI between reusable and disposable. So that's what we've been using. Gloves, there's not enough evidence to determine whether single or double gloving actually affect the SSI rate. And same for glove puncture rate and SSI. Okay. Intraoperative phase, antiseptic skin prep. There's no difference in SSI rate between chlorhexidine and povidone. So both are equally good. And then there's insufficient evidence to compare between chlorhexidine or iodine against alcohol. No difference between single and multiple application of povidone. So you can actually just apply just once of povidone when you're skin prepping. Don't have to do it many times. because there's no evidence to suggest that it makes any difference. Diathermy, no difference between made by scalpel or diathermy. There's not enough evidence comparing diathermy and laser or harmonic scalpel. Wound irrigation and intercavity lavage. Subcut wound irrigation with povidone or saline under pressure reduce SSI. Okay. No difference between antibiotics and saline wound irrigation, so you can use either. And no difference between antibiotic and saline intercavity lavage except one small study. So again, no difference. So might as well use normal saline. When povidone iodine is used for perineal space lavage, it's better or gives less SSI compared to saline. So this is for the colorectal or gynae, I suppose. Intraoperative phase wound closure. Topical povidone iodine spray prior to closure reduce SSI. So I don't think we have this at SASMEC, but it's an idea to reduce SSI. You can quick spray of povidone iodine. Using alcoholic iodine has no effect on SSI. This is for implant, basically gentamicin collagen implant into sternal wound, reduces SSI. This is, I think we have, orthopedic normally uses, it's called Collatem. Closure methods for skin, absorbable versus non-absorbable, basically insufficient evidence. Insufficient evidence again for tissue glue against sutures, and there's no difference in SSI between staples and sutures. Okay, and for cosmetic as well, actually there's not much different if you remove the sutures or staples at the appropriate time. There's no difference in dehiscence as well between tissue glue and sutures. Okay, obviously depends on where you're closing it or the tissue tension. Again, closure methods, internal layers, fewer SSIs when absorbable compared to non-absorbable in abdominal wall closure. So that's what we normally use anyway. We use absorbable. And there's insufficient evidence for risk of SSI for suturing versus not suturing, placing drain versus not in subcutaneous layer. Okay. Again, insufficient evidence for dehiscence or SSI for technique or material use. Wound dressing. So no difference between gauze and Vaseline ointment. No difference between hydrocolloid or this other modern dressings. No difference between another modern dressing. No difference between wound covered, for example, by melamine or tape, and covered for 48 hours. So you can leave it for 48 hours if there's no problem. And then no difference between wound dressing until removal of sutures and dressing for 24 hours only. So you have the option, if there's no signs of infection, there's no need for you to open the dressing unnecessarily. So you can wait until it's time for removal of sutures. Change of dressing, insufficient evidence to show the rate of SSI between clean and non-touch dressing technique for secondary intention healing wounds. Post-op cleansing, wound cleansing, no studies found. Post-op cleansing, showering on first or second post-operative day versus keep dry for 14 days or no shower, no difference. Okay, so you can either ask them to shower early or you can leave it Topical antimicrobials, this is what we normally practice. Actually, there's no difference in SSI between using CMC or not. Okay, so some people just make the surgeon feel better rather than actually have any effect on the wound. So apply CMC, but actually no evidence to show that it reduces SSI. Antibiotic treatment of SSI and treatment failure. Culture should be taken. First line antibiotic empirical should cover most likely organism, including Staph aureus. If it involves mucosal surface, you should cover with anaerobes. If the treatment fails, other non-effective reasons should be assessed. Example, the other factors that I've mentioned before: poor nutrition, or there's foreign body, or there's abscess or pus collection. So, in simple term, management of SSI: you drain the pus, debride, open wound care, delayed closure, reduce the bioburden, and involves multidisciplinary team. Okay. Sorry, I had to speak through that. Do you have any question? No?
Any question from the floor?